And so today I'm going to be talking to you about evaluation for subarachnoid hemorrhages. So I have no financial disclosures. And in preparing for this lecture, I actually thought of the last case I had of a subarachnoid. And it was a gentleman, he was at a restaurant eating alone, and he just slumped over. And so 911 EMS was called. He got rushed to the hospital. Upon arrival, he was, GCS of 3, not responsive, had the really sonorous respirations. And so we decided to intubate, got him off to the CAT scanner, and sure enough. And so I'm like, yes, I got it. And then I'm thinking, that's not a great catch, right? So he's the easy one. And so what I really wanted to focus on today are the ones that are needles in the haystack, right? So the ones that don't come in screaming, I have a subarachnoid. So there's really nothing earth-shattering about my lecture, but hopefully when you go back to your own shops, you have something that you can really think about. And as you approach this, you'll just think twice, and you're very aware of your workup for these patients. And why do we care? So again, as the previous speaker mentioned, there's a high rate of morbidity and mortality. And subarachnoids occur in a younger patient population in comparison to our ischemic stroke patients. And so they have longer years of disability if they survive. 25% of these patients die in the field or in your emergency department. And unfortunately for the gentleman that we had and diagnosed, he actually died within the emergency department. So I did want to touch on this. This looked at the last 30 years almost of subarachnoids, and what they found is there was actually worldwide a slight increase in incidence. But if you look at the age standardized incidence ratio, you did see declines in that area. And there's some areas that kind of accounted for this incidence. And so in China, as you can see in that color, they really had significant high incidence. They have done some targeted efforts. So in the last few years, you have seen a decline. And then the highest incidence ratio is actually in Japanese women. And so I thought that was actually pretty interesting to find out. So when we talk about subarachnoids, there's the traumatic and then there's atraumatic, right? And so the traumatic ones are kind of easy. Atraumatic accounts for about 6 to 9 per 100,000 of your subarachnoids. So those are the ones we're going to focus on. And then when we talk about the atraumatic, everybody always thinks about the aneurysmal ones, correct? So aneurysmal subarachnoids account for about 85% of those cases versus the non-aneurysmal. And so then when we break it down and we're talking about the aneurysmal ones, they're occurring majority of the time in your circle of Willis and in that anterior circulation. And so you want to think of that. And then under anterior then would be your middle, so your MCAs, et cetera. And they're typically going to be a saccular aneurysm that are causing this. So the patients that you may want to think a little bit longer about, does this person have a subarachnoid, would be the patients that have hypertension, they're smokers, gender, and again, it also may depend on where you're practicing, but versus the male versus female. And then don't forget your sympathomimetic drug use. So patients on cocaine, et cetera, have higher rates. And then the genetic factors, as was mentioned, I think, by the previous speaker. So patients with Ehlers-Danlos, polycystic kidney disease, Marfan's, neurofibromatosis, they have higher rates as well. And how do these patients present? So this is like our board question, right? So the patient, they were like, oh, they had a thunderclap headache, neck pain, and they syncopized. So that's easy, right? And then those are the ones that never show up in your ER, right? I don't know how many times I've actually had that. It's maybe one out of, the many that I have seen that actually presented just like that. And so when you look at it, there's a lot more atypical presentations that you'll actually see. So patients that come in with exam neck stiffness, patients, you have it on the exam or they complain of it. Patients with lethargy, patients with vomiting, similar headache in the past. And the reason I wanted to highlight these is the positive likelihood ratio for exam neck stiffness is over 6. And so these are in order. All of these on the screen have a higher likelihood ratio than the patient that says, this is the worst headache of my life. So I know we like to think about that in the classic presentation, but that one actually has the lowest likelihood ratio of all these symptoms when we're evaluating these patients. So just keep that in mind. So what can we use? Are there any rules? And for emergency medicine, a lot of you probably know, where do we always go when we want to find rules to use? we go over to Canada and we look at Ottawa. So there are some Ottawa subarachnoid rules. This initially was done, I want to say, early to mid 2000s, where they identified the criteria that I'm going to cover. And they actually have also done some validation studies since the original one. So what did they find? So it's going to be used, you're going to use this similar to the way you use the PERC score, right? And so if they have any of these, then you can no longer just say this is not a subarachnoid, similar to our pulmonary embolism risk criteria. So the patient must be younger than 40. They cannot complain of neck pain or stiffness. They also can be ruled out, or they don't fall into this if they've had loss of consciousness, if the onset was with exertion. So if they say, oh my gosh, I was out running, doing my morning run, and then I just got this headache, then they would fall out as well. Thunderclap headache, and then limited neck flexion on exam. So the neck stiffness, it cracked me up, but I'm sure this is, you think of this and or you look at the whole list and you're like, these are, every patient I see with headache has something in there. So this was done across 6 EDs in Canada. It was 2,000 patients, and it did have 100% sensitivity. The specificity, however, was very, very low. So it is really good at ruling the patients out that don't have it. But then once you identify that they're 45 years old or was onset with exertion, then you need to continue on, right? So what are you guys going to do next? Oh, actually, before I go to next, so don't use these rules if the patient has a new neurodeficit, which I don't think anyone here would blow that off anyway. If they have a history of an aneurysm, history of subarachnoid or brain tumor, and then also if they have history of similar headaches, and that they categorize as greater than 3 episodes over the last 6 months. So if they rule out on the first page, then you can stop, and that's pretty good. But if you cannot, then you want to keep going. So what do we do next? So I remember I had this one attending who, he was like, if any patient walks in and has a sniff of a headache, they're getting radiation, they're getting a needle in the back. And he's like, I don't even think about it. So I kind of trained with that mindset, like, okay, CT-LP, everybody. And now, of course, we have some newer mechanisms. We have CT angios, and those are coming into play. So we have a couple other things to consider. And then I'm sure you all are aware of the study that came out that's saying that, oh my gosh, you can do a non-con CT, and if it's negative, we're done, right? So that came out a few years ago, and obviously there were a lot of caveats to that. So first of all, the headache had to be within the first 6 hours. And if you did catch that, then you were almost 100% certain to be good, saying that. But there are a couple other caveats. So one, I'm not sure where everyone's practicing, but you need to have a 3rd generation CT scanner. So you need 5 millimeter cuts or better. And then the patient cannot be anemic. So you need to have a hematocrit greater than 30. And they also want you to have an attending radiologist read. So if you work at a shop at night and you have an intern radiology resident reading your CTs, you may not want to just stop at the 6-hour rule and say, oh, this patient's 6 hours. You may not want to stop. So again, that CT also loses specificity the further out you go. So it's still a good test. Obviously, we're all going to do it. But you go from 6 hours around 100%, and it slowly starts to drop. So 72 hours, you're dropping to your low 90%. 5 days out, you're 50-50. So the specificity declines to about 50% at 5 days. So, and this also is about a level B recommendation according to the American Heart Association. So what do we do next? So who here is gets your CT, the patient is beyond 6 hours, so you're going to keep going. Who does an LP next? Only 2, 3, okay. Who does a CTA next? So more hands for that. All righty. So neither one of you are wrong. That's a good answer. So when we're looking at LP versus CT, I think the biggest thing is to just be aware of all of the limitations and the risk, right? And so with LP, the biggest challenge is interpreting your results, right? And so when do I know if this is truly a subarachnoid or a traumatic tap? And so really what you want to do is if you have RBCs in your last tube of greater than 2,000, then you can say that's a bleed. And you're pretty good. Depending on the timing, xanthochromia, if you're at 6 hours, if you're closer to 12 hours, xanthochromia should be present. and you definitely should be calling neurosurgery, and you should feel comfortable calling this a bleed. When you're doing your CTA, there's obviously risk there, right? And so radiation, whether you're a believer in the contrast nephropathy, et cetera, or not. And then also, the bigger challenge is you can actually find incidental aneurysms. So you find an aneurysm, but it may not be actually what is causing the patient's symptoms. So about 10 to 15% of patients with aneurysms walking around, only about 10 to 15% have symptoms. So something to keep in mind is you may find an aneurysm, but it's actually not the cause of their presentation today and their headache. So you really just have to be very, very, very cognizant of all the risk and the limitations of whichever algorithm you decide to create. They both have a level C recommendation. And so sometimes what I'm finding is you do the LP and you're still questioning it, so then you do the CTA. And then some do the CTA, you find an incidental aneurysm, and now you're like, oh, now I got to go do my LP to see if it's bleeding. So you just kind of work in a circle. So once you get to that circle and spiral, what do? You're going to phone a friend. And so at this point, I would call neurosurgery. And so, every place where you go, different story for neurosurgery, but they can really be helpful in this conversation. So given the presentation, kind of run the presentation, all of your findings by them, and then you can go ahead and proceed with your case. But and again, you can also admit these patients for observations. While they're in-house, you can look for further investigations, right? So if you're really worried about an aneurysm, especially if this patient may have a family history. So other things that they're doing now in-house, so not to be done in the ER, but once they're admitted, you can consider digital subtraction angiography, MRAs. So MRAs are not really helpful in that first initial workup in the emergency department, but once you get in-house, if you still want to further investigate an aneurysm, not necessarily the bleed, but an aneurysm, you can do the MRA. And they're also now looking at transcranial Dopplers for also diagnosing aneurysms. So those are other things that can be done once you have a disposition. So if you're admitting the patient or they're going to get a workout outpatient and you've been able to arrange that, those are other things to consider. So I know I've talked really rapidly. I was trying to catch us up. But really, just to summarize, again, you don't really want to miss this diagnosis. It is crucial. Of the subarachnoids out there, about 5.4% of patients actually are misdiagnosed on their first presentation to the ER. And again, they have high rates of morbidity and mortality. So you don't really want to miss it. You want to catch it. But again, it's almost inevitable. Don't forget the Ottawa subarachnoid rule. So if they fall out and have none of the 6 criteria, then you're done. So again, that is going to rule out a lot of the younger population that may be coming in. But something to consider. Also, don't forget to, when you're doing your workup, work up wisely and just know the limitations of what you're doing. So if you're having a conversation with the patient or with the neurosurgeon, like, hey, I know this is not foolproof, but this is what I have, this is what I'm thinking, and then have that conversation with the patient and with the consultants as well. And that is about it. Did I do okay on time? All right.